The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Welcome to our first Communicable Disease Forum webinar for the year 2019. Thanks for making time and attending today. My name is Sharif Ibrahim. I work with the Regional APA program, and I'm glad to be the host for this webinar today. We have a really rich agenda, and I hope you all enjoy it. So, as usual, and you guys used to this, our webinar today will be recorded and archived and posted in our NJDOH website. You can access the webinar at any time at your convenience. Today's credit offered will be 2 public health and nursing credit. You must also be registered at NJLMN, and you must be registered at GoToWebinar. Those only who get credit, those who are viewing the webinar. If you will view the archived version, you will not get credit for that. Your lines should be muted today. Please use the question box to ask any questions. Questions will be answered at the end of the webinar if time allowed. Your handout can be accessed in the handout box. Handouts on the GoToWebinars are only available to you during the live webinars. You can access the handout also from NJLMN in Practice Exchange. After the webinar, you will receive a link to the evaluation. If you are seeking continuous education credit, you should complete the link within 5 days. This link will be closed after 5 days. Your certificate will be emailed to the address that we have at NJLMN after we get the evaluation. Those who do not complete the evaluation will not receive the credits. This announcement, we are glad to let you guys know that we will hold the in-person Communicable Disease Forum at the end of April and during the month of May. You have the schedule in front of you. Please mark your calendar, and we will hope to see you all there. This is our agenda for today, and our first speaker is not in the agenda. It's going to be a brief update on the Hepatitis A situation on the state. Our speaker today is one of our own regional epidemiologists, Brett Nance.
Hi, everyone. This is Brett Nance. I'm one of the regional EPIs here at the Communicable Disease Service. We wanted to provide you with a brief update on a links message that was sent out on Friday, along with some talking points regarding the increase in hepatitis A cases that are being seen in southern New Jersey currently. So the New Jersey Department of Health, in conjunction with Burlington County, Camden County, and Gloucester County health departments, are investigating an increase in hepatitis A cases, particularly among individuals who are experiencing homelessness and or are reporting drug use. This increase is not being seen anywhere else in other parts of the state across the other counties, and we are performing active surveillance to monitor increases across the state on a weekly basis. It's important to note that since March of 2017, the CDC, along with multiple other states, have been investigating outbreaks of hepatitis A in the same population. So this is a friendly reminder, just during your investigations of confirmed hepatitis A cases, if you come across a case patient who reports homelessness and or drug use, it is helpful to obtain information on any homeless shelters, encampments, or congregate living settings that they've been in, as well as other settings or locations where they may have sought healthcare or other services. We do understand that obtaining information from individuals in this population may be difficult. Sometimes reaching them is only possible while they're in the hospital, but any information that we could potentially obtain to give context to exposures or other people that may have been exposed is helpful. A little bit of information is better than none. So in terms of actions on this cluster that we're seeing, the New Jersey Department of Health is working with the mentioned health departments, local health departments, to support them in their outreach efforts to the at-risk population. This includes education and providing 317 vaccines, particularly targeting transitional housing, shelters, FQHCs, and other clinics and area partners for, within the local health department jurisdictions. If you have any questions about 317 vaccines or their availability, they can be directed to the contact information that's found on the slide. And if you have any questions just regarding the Hep A increase in general, or if you want to report an increase that you're noticing within your jurisdiction, you could just reach out to your regional EPI here at the Communicable Disease Service to discuss it further.
Our first topic in the agenda today is the school outbreaks. Our speaker is our subject matter expert in schools and daycares, Barbara Crothers.
Thank you, Sharif. So this morning, instead of the usual school outbreak reporting talk, I thought I'd discuss a few topics related to school outbreaks. I'll focus on a few areas that we seem to frequently get questions and comments on. But first, in case you're not familiar with it, I wanted to introduce our new school health page. We launched it last fall, and this is where you can find the outbreak guidance, school-related topics, forms, and other resources. You can find it by searching the disease and health topics list, A to Z. Why is it not going? Hold. Keep talking. Okay, little technical difficulties, but we'll get there. In addition to the school outbreak, a new addition to the school outbreak guidance is an outbreak checklist for schools. And in a minute, oh, there it is. Okay. Right now, it can only be accessed within the outbreak guidance document itself, but it's a great tool to share with your schools. It's a quick guide and not meant to be used as a sole outbreak guidance document, which is why it's kind of buried into the big document for now. I do update the guidance at least annually, usually before the school year starts, so be sure to check periodically for updates. Okay, so now let's talk about some questions and comments we seem to get from time to time. This is the boogers part. Currently, we're experiencing widespread flu activity, so schools should expect to see an increase in absenteeism of students and staff with respiratory symptoms. This doesn't always mean they have an outbreak. We all know that in a school setting, it's hard to determine if an outbreak exists. If a school is experiencing clusters of ill students or staff that are in the same classroom, maybe the same grade or wing of a facility, or they've attended a common event, then they may have an outbreak going on. But during flu season, we would expect a school to experience cases of flu and ILI, but unless they're experiencing what I just described, they wouldn't need to contact public health. Poll question? Okay. Go ahead.
We're going to launch a poll question.
We're going to launch a poll question.
So which statement is true?
Schools should close for cleaning during an outbreak. Only kids under 5 get hand, foot, and mouth disease. All cases of hand, foot, and mouth diseases are reportable or none of the above.
Okay. And we have about 70% of participants voting. So let's give them a few more seconds. And we're going to stop collecting. And let's share the results. So Barb?
Okay, so 60% none of the above.
Is that the right
That's
answer?
the right answer.
Yay!
We do not recommend that schools close for cleaning during an outbreak, although it does happen. Anybody can get hand, foot, and mouth. Most likely we see it in kids under 5, but anyone of any age can get it. And no, not all cases are reportable, just outbreaks.
Okay.
So, okay, good job.
Great.
Okay, so let's finish our information about flu. Oops, that's not where I want to go. No. Okay, that's where I want to be. So, okay, so what should a school do about absenteeism during flu season, right? So let's talk about some of the questions and comments we usually get about that. So if the school that's reporting doesn't have an outbreak, but they are seeing an increase in absenteeism for respiratory symptoms, they should be told to continue to monitor for sudden increases of fever and respiratory symptoms. And if they start to experience clusters, they should report back to you. Anyone with sudden fever and respiratory symptoms should be sent home with instructions to stay home until they're fever-free for 24 hours without fever-reducing meds and to seek medical care if symptoms worsen. So at this point, it's a good idea to let parents know what's going on, maybe a letter telling them there's an increase in respiratory illness or there is an outbreak going on, reminding them of prevention measures and exclusion. I have some templates and we're happy to share with you if you need them. Last flu season, and again this fall prior to flu season, we sent out a respiratory outbreak guidance document outlining what I just described. If you haven't seen it, it can be found both on our school health page and on our flu page. So we get this question from time to time. During a flu outbreak, should well children with religious exemptions be excluded from daycare? So the question pertains to the daycare kids that are part of the flu vaccine mandate. So that's kids 6 months to 59 years of age attending any licensed child care center or preschool. While we don't have formal recommendation about this exclusion of unvaccinated kids that are part of the mandate can be considered as an additional outbreak control measure. But since I've been doing school outbreaks, we really haven't made this recommendation. This would definitely be done on a case-by-case basis. If the school decides to initiate this as a control measure, they certainly should contact public health. In this case, again, reminding the parents of prevention for flu and exclusion, and let them decide if they want to send their unvaccinated kids to school. So we get reports of a variety of rash illnesses, but the one we hear about the most is Coxsackie virus, or hand, foot, and mouth. As you all know, it's a common viral infection that usually is mild and most commonly caused by Coxsackie A16 and enterovirus 71. Symptoms include tiny blisters on the hands and feet, respiratory symptoms, fever, and sometimes vomiting and diarrhea. Coxsackie is spread person to person by respiratory or fecal-oral route, and it's common in infants and kids under 5. That's where we see it mostly, but because they don't have immunity for the viruses that cause it. But however, older children and adults can also get hand, foot, and mouth disease. Although there are lab tests that can be done, most infections are clinically diagnosed. There's no vaccine or specific treatment. The virus can live on surfaces for several days, but routine disinfection procedures are usually effective for hand, foot, and mouth. Although we can see at any time of the year, we do tend to see an increase in the summer and early fall. So like flu, it can be seasonal. Schools should expect to see cases early in the school year, and daycare centers would see cases earlier than that. Many of you probably remember a couple of years ago in August and September, we did have, that was in 2016, we did have several outbreaks of hand, foot, and mouth disease among high school football players. Because football games were canceled and schools were in different counties, it was all over the press. Although we were receiving reports of outbreaks within the teams, a lot of what we were hearing were sporadic cases, a variety of respiratory and viral infections. So we were getting calls from schools that had, a few cases and not really outbreaks. Again, schools should expect to see cases, but it's not necessary to report to public health unless they have clustering. This past fall, at the request of the School Nurses Association, we sent a communication similar to the flu information for schools outlining, reporting and identification and prevention. We're happy to share this and other resources that we have if you need them at some point. Last year, we had 68 cases of outbreaks of hand, foot, and mouth disease reported. 41 of them were within a daycare, 26 school, and 1 camp. So now the poop part. The most common cause of acute gastroenteritis is norovirus. I'm sure you all know how quickly norovirus can spread in a daycare center, nursing homes, schools, even cruise ships. You only need a very small infectious dose to get sick, so when a kid vomits in a classroom, you can be assured that you're going to see more cases after that. Although most people recover in 12 to 72 hours, the virus can shed in the stool at least for 2 to 3 weeks after symptoms resolve. Disinfecting with an appropriate product for norovirus is very important. The first thing you want to ask when you have a GI outbreak is what product are they using for cleaning and disinfection. For some organisms, routine cleaning procedures are fine, but when we have a GI outbreak, unless you know the organism, cleaning and disinfection should take place as if it's norovirus. Schools are often using a green cleaner, which is not effective against noro, so it's very important to have them use an effective product as soon as possible. You don't want to find out a few days into the outbreak that they're cleaning with something that's not effective. We recently had a pretty large norovirus outbreak in a daycare. By the time we found out what they were cleaning with and how they were cleaning, it went through the entire facility. So that's how quickly it can spread. So that particular daycare was like, oh my God, everybody's sick. They're dropping like flies. Can these kids get this again? Unfortunately, yes. You can get norovirus many times in your life because there are many different types. But it's believed that there is short-term immunity after infection, about 14 days. But it's possible to develop protection against specific types, but it's not known exactly how long immunity lasts, which kind of explains why so many people of all ages can get affected during a noro outbreak. We do have specific norovirus outbreak guidance on our school health page as well as the norovirus page. And again, we have templates and other resources that we're happy to share. So aside from norovirus, we do see other GI pathogens in school and daycare settings. Shigella, Salmonella, and Stec are a few that we see from time to time. So when you get a report of a school-age kid or a daycare attendee or staff member with one of these pathogens, first thing you want to do is check the school exclusion list to see if negative stools are required in order for a child or staff member to return. Exclusion for daycare and school-age kids can be different. For example, for Shigella, if you have daycare children under 5, they need to have 2 negative stools and be symptom-free before they return. School-age kids would just need to be symptom-free. So just to kind of clarify the age 5, if they're 5 and in daycare, they need negative stools. If they're 5 and they're in school, then they just need to be symptom-free. We often find out that kids return to daycare without having additional testing, and most likely then they're going to be excluded until additional testing is done. So it's helpful to find out from the start and let the doc know and the parents know and the daycare. So we do get outbreaks reported associated with sports teams now and again. Over the past several years, we have seen a variety of outbreaks in sports teams. We commonly get viral, fungal, bacterial skin infections because that's the contact sports like wrestling and football seem to be the breeding ground for those. Earlier I mentioned hand, foot, and mouth outbreak among the football players that involves several counties. Other reports we get are MRSA, pertussis, we've had ringworm, impetigo, scabies, and a couple years ago we had a viral meningitis and positive NRO with football teams. That involved a couple of the schools. So when we get an outbreak of a report of outbreaks associated with sports teams, we ask the schools to follow the general outbreak guidance, but when they have outbreaks related to skin infections, our recommendations are based on the guidance from the NCAA Sports Medicine Handbook and the USA Wrestling Guide for MRSA. Both are available online for free. I reference them at the end of the presentation. Most often, though, the coaches and trainers know to follow the guidelines, and they're already doing that before we get the call. So a little bit about cleaning and disinfection. I could probably do a whole 20 minutes for you on that, but I'm going to try to hit some just important points. Schools should have policies in place for routine cleaning and disinfection as part of their infection control plan. And their policy should focus on controlling the transmission of disease while protecting the people in their building from the ill effects from using harsh chemicals. Basically, there are 3 main levels of microcontrol in schools. That's cleaning, sanitizing, and disinfecting. All-purpose cleaners like the green cleaners and soap and water remove dirt, bacteria, and viruses by the physical action of scrubbing. Sanitizers reduce levels of microorganisms of non-porous surfaces like metal or glass or hard plastic, and they must be registered by the EPA. Disinfectants kill multiple organisms, including bacteria and many viruses, and disinfectants are pesticides regulated and registered by the EPA. So schools should determine what level of cleaning and disinfection is appropriate for the surface or the object before choosing their product. There's a really good toolkit for cleaning in child care centers on our DOH environmental health page. It has good information for daycare centers, and I also reference that in a couple slides. So when asking a school about products that they're using, it's important to ask them to read the label. Sometimes we ask them to send us a picture because manufacturers change, product name changes, and it's hard to find them on the EPA list. So if you have the number, it's a lot easier to find the product. Basically, those schools should use a broad spectrum product for disinfection that's registered with the EPA according to the manufacturer's instructions, or a self-made bleach solution prepared daily, labeled, and sealed. But some of the questions you want to consider when you're asking about cleaning: is it EPA registered? If it's not, then it's a cleaner and not a disinfectant. What's the active ingredient? So if we have an outbreak going on, does this ingredient work for the organism that we're dealing with? How should it be used? Maybe it requires dilution or can only be used on certain surfaces. So are they using it properly? They could be using the right product, but not in the right manner. What's the contact time or the length of time the product has to remain wet on the surface? A cleaner that has a contact time of 10 minutes might not be reasonable for cleaning staff to use. So incorrectly using a disinfectant can enable bacteria that survive on the surface to become resistant. Exclusion. Exclusion is probably one of the biggest challenges for the school nurses during an outbreak, and I hear that from many of them. General rule is that anyone who's sick should stay home. We do have disease-specific exclusion on our exclusion list. But if an illness doesn't require exclusion, but it prevents the child from participating comfortably in activities, or the child requires more care than staff can give, then temporary exclusion is recommended. Temporary exclusion is more utilized in a child care setting than in a school, but it is an option. So doctor's notes. We get this one a lot. The doctor gave me a note, so I have to let the kid back in. As we talked about a little earlier with Shigella, certain diseases require follow-up before returning, such as negative stools or maybe a specific length of time they need to be on treatment. It is common for healthcare providers to give a note allowing the kids to return, and most schools have a policy for reentry with a doctor's note, but it's our experience that the healthcare providers are not aware of specific recommendations for reentry, like having negative stools. So when there's an outbreak or a case of a reportable condition, especially in a daycare age child, the school, the parent, and the healthcare provider should all be notified if follow-up testing is required before they return. So schools should have policies in place for notification to parents, but there's no hard and fast rule on when a notification should be sent. They should be sent on a case-by-case basis, depending on the type or severity of the illness or the magnitude of the outbreak. And not every outbreak warrants a notification. We always recommend that schools consult with their local health department before they send a notification. This way you can help them determine whether it's necessary or not. So we often get questions about what percentage of students must be ill in order to close a school. There's no magic number because we do not recommend school closure for outbreaks of infectious disease. The decision to close a school is a school district decision that should be made in consultation with public health and the school district medical personnel. We recently had a school that had 2 outbreaks going on at the same time. We didn't recommend that they close, but we did appreciate that they consulted us first. So we weren't surprised because we usually find out after they're closed. That's not always the case, but, you know, we were happy that they consulted us. Not that they listened, but if absolutely necessary, school closure should be utilized on a limited basis. Again, it's up to the school district. So again, this was a recent outbreak. The school administration is closing school to clean and disinfect because we have a flu outbreak. So as I said before about cleaning, when cleaning, sanitizing, and targeted disinfecting are part of the infection control plan, it's not necessary to close a school to clean or disinfect every surface in the building to slow down the spread of flu. And most studies have shown that the flu virus can live and potentially infect a person for up to 48 hours after being deposited on a surface. But again, it's not necessary to close a school to clean or disinfect. Again, it's important to match your cleaning and disinfecting to the type of organisms you want to remove or kill. Flu viruses are relatively fragile, so standard cleaning and disinfecting are usually sufficient. Okay, so we're good. Here's some links to some resources, our school health page, the NCCA Sports Medicine Handbook and Wrestler's Guide. Again, you can download those for free. They're good to keep on hand. And then we have a good resource from the National Education Association on cleaning classrooms. And then the last link is the Child Care Center Cleaning Toolkit from our environmental partners. So thank you.
And it is influenza season, so we are lucky. We have our influenza expert, Dr. Lisa McHugh, to talk to us about update on respiratory virus season.
Thank you, Sharif. Good morning, everybody. Thanks for joining us. I'm hoping to just give you some updates and talk about some relevant points. Barb covered some of the issues with schools. I'm going to talk a little bit about some of our issues in long-term care facilities. First, just a brief overview of kind of where we stand with the current 2018-2019 season. This year began a little bit earlier. We actually started to see activity in early November, which is pretty early for New Jersey. While it's really too early for us to say whether we've actually seen a peak, it does appear that our activity is beginning to come down. So it's likely that we are past the peak, but I never like to say definitively because you never know what's going to happen. So far this season, we have seen a pretty strong signal for influenza 2009 H1N1 and has been the predominant virus to date. Although recently we've seen a transition from 2009 H1N1 to influenza AH3, and that occurred right around the middle of February. So we continue to see a large number of influenza H3 in New Jersey. The intensity of this season is tracking closer to a typical season of influenza, so we're not seeing a high-intensity season like we experienced in the 2017-2018 season. All early indications talk about good vaccine match, and I have a few slides on vaccine effectiveness that I'll share with you in the recent results that came out in February. So again, just a reminder that we do produce a weekly respiratory virus surveillance report that includes information both on influenza and other non-influenza viruses that are circulating in New Jersey. This goes out through the New Jersey Links system or the Health Alert Network system and is also posted weekly on our website, and the website is at the bottom of the page there. So as I mentioned, I just want to briefly highlight some recent information that was published by CDC on vaccine effectiveness. Again, just to orient you to the table, you want to look at the very last column, which is the adjusted percent of vaccine effectiveness. And then it breaks it down by a couple of different things. So the first one of 47% is overall the vaccine effectiveness for both influenza A and influenza B. And then as you go down, you can see the vaccine effectiveness for influenza H3, which was 44%. And then for influenza A 2009 H1N1, which was 46%. And you can see the breakdown there also by age. Just as a comparison to what this looked like compared to last year, so in those boxes on the far right hand of your screen, you can see that last year overall the vaccine effectiveness was about 7% lower at about 40%. So there has been an increase in the vaccine effectiveness seen this year. H1H3 has gone up significantly from 24% last year to 44% this year, and a slight decline in the 2009 H1N1 from 49% to 46%. And again, these are estimates as of mid-February. Again, there'll be additional estimates that get produced at the end of the season as well. So we'll be looking forward to those. So just want to highlight, again, we continue to get this question. As you know, influenza is a laboratory reportable condition, which means influenza labs do get entered into CDRSS. But we do not require local health departments to conduct investigations into those unless they meet the following criteria. So for pediatric influenza, we're looking for children who are less than 18 years of age who have been admitted to an intensive care unit or have died, or the laboratory is indicative of a novel influenza strain such as H5, H7, or and subtypable. I will mention to you that we've had a lot of laboratories who are reporting novel influenzas into CDRSS. And it's not so much that they are novel influenzas as much as it is that there are some concerns over some of the commercial laboratory tests and their ability to actually identify 2009 H1N1, which we've been seeing a significant amount of this season. And so when those particular things happen, those laboratories are entering them appropriately as novel influenza. We ask those laboratories to then submit those specimens to the state public health lab, where we then run them on the CDC assay and confirm that, in fact, they are a seasonal virus. So to date, there's been no novel influenza cases. Those specimens have been rolled out at the state public health laboratory. So cases, again, that don't fall into these categories do not need to be investigated by the local health department. So one of the things that I will just ask is we've had some circumstances recently where there have been cases of pediatric influenza mortality that have been put into CDRSS, and we've been unaware until we've actually done our weekly surveillance runs. So of course, pediatric influenza is not an immediately reportable condition. However, we kindly ask that if you do see a child in CDRSS that has died of influenza in any type, please notify us so that we can begin our investigation as soon as possible. It does help with us acquiring specimens. When we learn about these things a week later, often specimens are discarded and we're unable to confirm that an influenza was present using the CDC assay at the state public health lab. So again, if there's any inkling that a child does meet the definition for mortality, please give us a call, and our contact information is on the last page of these slides. And so to date, we've had 3 confirmed fatalities. The slide is slightly old. There was one earlier this week before I made these slides. We've had 22 severe cases reported so far, and there have been 28 fatalities reported nationwide. And you can see the comparisons on the slide to previous influenza seasons. So just shifting slightly gears here from seasonal influenza surveillance to respiratory outbreaks in long-term care facilities. I just want to kind of review some of the common questions that we often get by highlighting some of the things in our guideline document. So for those of you who are not familiar with these guidance documents, they're located, here's the title of the document, and they're located on the following web link. I highly recommend that you review the documents on the website so that when you do get a call from a local health department or a long-term care facility, you know how to respond. So just a quick review of the definitions of what a respiratory outbreak is. One laboratory confirmed case of something, whether it be influenza, RSV, adeno, etc., in a resident, along with other cases of respiratory illness on that unit, would be considered a confirmed respiratory outbreak. Or a sudden increase over the normal background rate of acute respiratory illness with or without documented fever. And again, we talk about the increase in temperature because many times, especially in long-term care facilities that are where older folks reside, sometimes they don't mount the same type of fever as we would expect. So we consider that 2 degrees above baseline for any particular resident. So again, I think everyone's familiar that part of New Jersey Administrative Code, Title 8, Chapter 57, all facilities must report suspected outbreaks to the local health department where the facility is located. Of course, we know that there is likely significant underreporting, as many long-term care facilities may not truly understand when they have an outbreak that's going on, particularly with something like the seasonal illness such as influenza. We would encourage our local health departments to develop networks with their long-term care facilities so that they know who they should be contacting when they think something is happening or when an outbreak may be occurring, to try to help them prepare them for outbreaks before they occur. So making sure that they do have infection control plans in place, that they know who they can reach out to, they know what surveillance is, they know how to fill out a line list. All of those things are really helpful to understand before an outbreak occurs so that you're not trying to teach them on the fly. And then just to familiarize the facility with our outbreak guidance so that if there are things like standing orders or something else that they need to put in place, again, they can do that before the outbreak occurs. The one thing I do want to mention that we've started to do is to try to use some of the surveillance data in CDRSS to our advantage to actually try to identify some of the outbreaks that might be occurring in these long-term care facilities. Again, as I mentioned earlier, we know that there is likely underreporting. And so we do run our CDRSS data for common addresses. And if we see that there are common addresses, we look those addresses up. And if they happen to be associated with some type of institutional setting, we do send that over to our regional epidemiology program, who then will likely reach out to the local health department. So just know that there may be some of that happening as well. I also wanted to highlight that this past fall and prior, our regional epi program has done some long-term care outbreak training, which was geared to both local health and long-term care folks. I think it's been a great training. They worked with all of us here to try to put on that training, so I hope that you were all able to attend that. And I know that there's been some thought processes of how to move that training forward in the coming years. So just to highlight the respiratory outbreaks that we've seen thus far, again, the number that typically gets reported varies significantly each year, typically coincides with the predominant strain that we've seen. So for example, in 2007 and 2018, where we had a high intensity season, we had 208 reported. And by week 7, which was last week, we had 156. And so far to date in the 2018-2019 season, we've only had 60 reported, so a little less than half the number reported if you compare it to last season. So outbreak reporting. I just want everybody to be familiar with the investigation and outbreak intake record, also called the CDS 36. This is actually available on the forms page, and that link is at the bottom left of this slide. And what essentially this is that it provides just the basic information about an outbreak that can help you if you're talking to a facility, just make sure that you're collecting all of that information so that when you call us, you don't have to go back and forth with us. You kind of get all of the salient information in one form for outbreaks. I would say that also for influenza outbreaks, there are a few other key pieces of information that we'd like you to collect. And that includes a type of test performed, rapid versus PCR versus a respiratory virus panel or an RVP. Again, these tests have different sensitivities and different specificities, and so it's important for us to know what we're dealing with and whether we need to request additional specimens be sent elsewhere for additional testing. It's helpful to know the vaccination rates in residents and staff. It's helpful to know if there's been any hospitalizations or any deaths. And we would also encourage you to let the facilities know that you'd like to know frequently about any new hospitalizations or deaths that may be occurring associated with an outbreak. Antiviral treatment, whether treatment and or chemoprophylaxis has been administered, and we'll talk about that in a few slides. And then the current outbreak response steps that have been taken or the recommendations that you as a local health department have provided. So I'm not going to go into this significantly, but I just want to kind of talk briefly about the steps in an outbreak response. So, there's certainly testing, there's monitoring, asking for daily surveillance of both residents and staff, creating of line lists, and we'll talk about that in a second. Control, which would include standard and droplet precautions that are being implemented. Cohorting, meaning keeping the ill folks together and keeping those that are not ill separate from them. Trying to limit staff movement between those that are ill and those that are not, canceling or limiting group activities to the extent possible, providing treatment or chemoprophylaxis, and then certainly providing signage and visitor policies, and then offering vaccine to residents and staff. So just want to quickly highlight the respiratory symptom line list. Again, this is a CDS-11, and it can be found at the link at the bottom left of this document. And again, just a couple of things to talk about here. It's really important to make sure that this is legible. If you're sending or faxing it to us and we can't read, again, it's going to mean multiple back and forth with you or with a facility. So if you can print it or type it in as clearly as possible, that's very helpful. Making sure that it's complete. Often we get line lists that have initials and something in the comments and nothing else has been filled in or completed. Again, it's really important for these to be completed. Additionally, it's also important for there to be both residents and staff that are recorded. Often we get residents on here. We'll ask if there's been ill staff. They say yes, but they don't have a line list started on them. So again, it's important that it includes both. So just quickly shifting gears to antivirals. Just want to talk about when there's a confirmed influenza outbreak. Or even an individual case where there's not a confirmed outbreak, we would definitely recommend treatment. Again, treatment is given to individuals who are already ill. It should be given to all residents who have suspected influenza, and you should not be waiting for laboratory confirmation to administer that treatment. So just as an example, Tamiflu is one of the more common antivirals, although not the only one. This would involve 75 milligrams of Tamiflu twice daily for 5 days. Again, I've provided a link below that provides an antiviral summary that describes other types of medications and special considerations for antiviral medications. Chemoprophylaxis, however, is given to those who are exposed but who are not yet ill. And again, this is designed to help prevent additional cases of influenza from occurring, particularly in many of these long-term care settings where there can be significant complications associated with influenza. So if there's a confirmed outbreak, again, one positive and others ill within the facility, antiviral chemoprophylaxis should be provided to all residents, not just those residents of the outbreak affected unit, not just the roommate, not the friend, not the family member, all residents. For institutional outbreak management, antiviral chemoprophylaxis should be administered for a minimum of 2 weeks and continue for at least 7 days after the last known case was identified, and that's whichever is longer. So for example, with the Tamiflu, it's about 75 milligrams once daily, and again, at least for 2 weeks, sometimes longer if the cases continue. Additionally, we would also recommend that there be a consideration for offering chemoprophylaxis to unvaccinated staff. So outbreak control measures should be continued until an outbreak is declared over. And in general, we use 2 incubation periods without a newly identified case to indicate when an outbreak is over. So for influenza, we typically use 7 days. A final outbreak report is required from local health departments 30 days after the outbreak is declared over. That is per regulation. And local health departments can use a CDS 30 form in order to do that. And the link for that form is at the bottom left.
So now we have 2 polls. All right, there we go.
So once a flu outbreak is confirmed in a long-term care facility, prophy with antiviral should be offered to roommates of those who are ill. True or false?
So far we have 15% voting. We have 50% voting. All right, and make your choice. We're going to close the poll. And here's what we have, Lisa.
Okay, so this is a little bit of a tricky question, and I actually meant this to be a trick question. So the answer really is false. The only people you want to offer prophylaxis is not to roommates. Again, certainly the roommates of those who have, if your roommate has influenza, you should be offered prophylaxis, but prophylaxis should be offered to the entire facility if there's a confirmed flu outbreak, not just the roommate of the person who has the illness.
And I believe we have another one.
One more poll question.
And the fun continues. And here we have another one.
So the question is, when can you call an influenza outbreak declared over? After there are no new illnesses, 7 days after the last known case, 1 incubation period after the last known case, or once everybody has been treated.
All right. And we have about 25% voting. Oh, this is going to be a good one. She woke them all up with that question. I know, because she was sneaky. All right, so make your selection. We have just a little over 70%. I'm going to close it. 5, 4, 3, 2, 1. And here we have the results, Lisa.
Okay, so it looks like we have most of the people, the majority, 53%, gave the correct response, which is, again, 7 days after the last known case or 2 incubation periods. I do see we tricked some people with the 39%. With 1 incubation period, again, it's 2 incubation periods after the last known case, which for influenza, the incubation period is about 2 to 3 days. So we round that up and we use 7 days after the last known onset.
Awesome. Thank you. Thanks, Lisa.
All right. Thanks, everybody. There's my contact information. In addition to the influenza advisory group, you can always use that to reach out to the influenza team here at the state.
All right, switching topics now from influenza to, big shift to sexually transmitted disease on the rise in New Jersey. And our guest speaker from sexually transmitted disease program is Emilia Hammerman.
Thank you. Good morning, everybody. I'm very glad to be here and to be presenting this. Should I be clicking the right?
Right inside.
Okay.
There you go.
All right. So, what I want to do in my 20 minutes is which I'm going to go over. I'm going to go over some STD trends to tell you a bit about what's going on in New Jersey. And then we're going to talk a little bit about how we talk to patients and clients about sexual health. So, the first thing, the basic take-home message is STDs are definitely on the rise. This is an infographic from CDC showing the drastic increases since 2013 nationwide. When we compare New Jersey to the United States, we see that we are also having significant increases. With chlamydia, our increases are very much like that of nationwide. In gonorrhea, a little bit less of an increase than the overall country. Primary and secondary syphilis, a bit more than the rest of the country. And congenital syphilis, as you can see, there's a 154% increase from 2013 to 2017 nationwide. In New Jersey, we went from 0 cases to 13 cases in 2017. So looking at sort of just overall trends of chlamydia in New Jersey, you can see we sort of just had a steady increase since 2012 with over 35,000 cases in 2017. When we look at this by gender and age, we see overwhelmingly that we see chlamydia cases in our young females under 25. That's where we see most of our chlamydia cases. Yes, as some of you are probably wondering, we do have more targeted screening toward that population, and when you look for the disease, you're going to find it, but it's also is there to be found. So chlamydia is very common among this age group and young females. When we look at the counties, we see Essex, Camden, Hudson, Passaic, and Middlesex are our highest 5 counties for chlamydia. Doesn't mean it's not high in other counties as well, but these are our 5 top ones. Moving on to gonorrhea, as you can see, we had a little bit of a decrease and a dip there for a few years, and then we're right back increasing with the steps up, and we keep increasing there as well. Dividing this by age and gender, you can see it's more skewed towards males, younger males than is chlamydia, but it's still certainly in young females as well. And when we look at the counties for the highest counties for gonorrhea, Essex, Camden, Hudson, Passaic are still there. Middlesex replaced by Mercer. But again, just because these are the top 5 doesn't mean that it isn't in high rates in others as well. The red ones also have high rates there. All right, moving on to syphilis. This is sort of a steeper staircase, as you can see, this sort of increase since 2012. We've had a very steady increase of early syphilis in New Jersey. Breaking this down by age and gender, we see that it's very heavily skewed toward our male population. We see it's a lot of males in their 20s and 30s, and particularly in men who have sex with men. That is where most of our syphilis cases are reported. However, we are seeing more cases in other populations as well, but still very heavily in males. Breaking this down by counties, Essex, Hudson, Bergen, Passaic, and Union are our top 5, all up there in the north around New York City. There's lots of people living there, and when there's lots of people living somewhere, you're going to see more STDs, more disease in general, and certainly more STDs. Again, we also see higher rates with the red counties as well. So we are also, although they're not in the top 5, we are also seeing increased rates in Camden and in Mercer County as well. In Atlantic, yeah. So I wanted to spend a minute talking about congenital syphilis, since this has sort of was kind of thought to sort of be a thing of the past a little bit, that not something we need to think about or consider a lot, but we're seeing that it is coming back, and we are seeing increased rates. So one thing that we see is when we see increases in primary and secondary syphilis in women, we're seeing that also in babies, which kind of stands to reason. So nationally, between 2012 and 2015, primary and secondary syphilis cases in women increased by 58%. And then lagging behind that slightly, we had a 154% increase between 2013 and 2017 of congenital syphilis. Similarly, in New Jersey, from 2012 to 2015, there was a 37% increase in primary and secondary syphilis in women. And then we went from 0 cases to 25 cases in 2016 and 2017. in New Jersey, and we're looking to be in that same neighborhood for 2018, although our data is not finalized yet. So just, this might be a reminder for some of you or new for others. Some facts about congenital syphilis. This happens when syphilis is transmitted from a pregnant patient to a fetus, and it can occur during any stage of syphilis, although it is more likely in the primary and secondary stages, and during any trimester of pregnancy. Up to 40% of pregnancies in patients with syphilis will lead to miscarriage, stillbirth, or infant death. But even if there's a live birth, there's significant health issues in babies with congenital syphilis, like brain and nerve issues, meningitis, deformed bones, liver, and spleen issues. So it is a very, very serious condition. We take it very seriously. The good news, though, is that it is preventable. So if a pregnant patient is treated at least 30 days before giving birth, it's very unlikely that the syphilis will be transmitted to the baby. So some screening guidelines for pregnant patients. New Jersey law says that patients should be screened at their first prenatal visit and again assessed at birth for syphilis. However, CDC and ACOG recommend additional screening in the early third trimester if a patient is at increased risk. And what that means is if they have a history of syphilis infection or another STI, they've been incarcerated, sex work, drug use, they've multiple or concurrent partners, and if they're living in areas with higher rates of syphilis, that is also considered increased risk. Of course, all partners should also be evaluated and treated, because if a partner is not evaluated and treated, they will reinfect the patient. So in June, we released this health alert that you might have seen in response to our increasing rates of primary and secondary syphilis, and particularly that risk factor that living in an area with increased rates increases the risk for congenital syphilis. So the 6 counties listed in the health alert, Bergen, Camden, Essex, Hudson, Passaic, and Union, all had more than 80 cases of early syphilis in 2017. And so we are recommending that physicians who treat pregnant patients in those counties consider doing the additional screening early in the third trimester. So this is in addition to the first prenatal screening and the assessment at birth. In 2017, when we began to see this increase in congenital syphilis, the New Jersey Department of Health launched a public awareness campaign. So we have a webpage with resources. It has a press release. It has a poster in 6 languages that you can download and plaster all over the place if you want. There's a letter to healthcare providers. So please check that out if you would like some additional information and resources. Here's just an example of what the poster looks like in English and Spanish. And as I said, there's 4 languages in addition to this. So please check it out. And now it's time for a poll question.
Yeah.
Yay!
Yay!
So part of dealing with the increases in STDs is talking to patients and clients about their sexual health and risk factors. So with that in mind, here's a poll question for you. How comfortable are you talking to patients or clients about sexual matters? Are you totally comfortable? Be a bit nervous, but you could do it. Not sure, only if you had to, or you never want to have that conversation.
So it looks like we have close to 50%. Give folks a few more seconds. All right. And we're going to close the poll in 5, 4, 3, 2, 1. And we'll share the results.
Okay. Well, this is great. Honestly, I did not expect totally comfortable to be so high in the responses, but that's great. And I see a lot of folks are a bit nervous, which is completely understandable. And some not sures, and I'd only if I have to. I'm glad that no one never wants to have that conversation. One person that, you know what? It's understandable. And hopefully in the next 10 minutes, I'm going to give you or so, shorter, hopefully, I'll give you some resources to help you be able to do this a little bit better. So let's talk about this. Okay, so it is hard. This is a difficult conversation. It's a difficult topic to address. It is not in our culture. It is not considered a polite topic of conversation to ask somebody about their personal sex life. Let's face it. In our culture, there's definitely sort of an unwritten rule that sex is something that you do. It's not something you talk about. And that makes it very difficult because this is a very important part of someone's overall health and well-being. So just to sort of put that out there. But it is important to talk about this. It's very important in public health and when we're dealing with patients and clients. And in fact, patients actually, they want to talk about this. Surveys show that they do want to talk about it, but they don't think their provider really wants to talk about it. So that's something to consider. It's an important conversation because it can enhance a relationship with a provider. So it provides opportunities to educate and counsel patients about HIV, STDs, and viral hepatitis. And you can connect patients to treatment and care. And also an important thing is there's really not a lot of other ways to know what tests or vaccinations a client or a patient should have because STDs very commonly are silent. Most of the times they do not exhibit any symptoms or noticeable symptoms. So somebody might not know that they have an STD until there's more serious health issues. And in the meantime, they can spread the infection to other partners without realizing it. So it's a very important conversation to have. When taking a sexual history of a client or patient, the most important things to hit are the 5 Ps. Partners, so you want to know how many partners that they have had in the recent past and how often they have sex. Names, if you can get them, that's helpful. Practices, so what kinds of sexual contact are they engaging in? Oral sex, anal sex, penile-vaginal sex? Are there other sorts of play or things that they do that might increase their risk of being exposed to bodily fluid, vaginal fluid, semen, even blood, if that's possible? You want to know what they're doing to protect themselves from STDs. Are they using condoms? Do they use condoms with every partner or just some partners? Do they use them all the time? You know, that sort of thing. Are they using any sort of other barriers? Their past history of STDs and any plans that they have for pregnancy or to prevent pregnancy. And that's a question not just for female patients or patients that could get pregnant, but partners as well. So that's important to know because that will certainly impact what they are using when they have sexual relations with each other. There's a lot more information about this on the CDC website, and there's a link right there. That's a very helpful guide, and I recommend it even if you're not a provider. It gives good pointers for how to have this conversation. So just some tips, and I'm just going over these things sort of fast, and I'm going to give you some resources which are really going to delve and be more helpful to you. So it's important to sort of set the stage for this conversation. I know that's kind of a fun picture there, but setting the stage is important. So you need to create a welcoming and inclusive environment. So if you're going to have this conversation in an office, look at the office, look at the waiting room. What artwork is on the walls, what posters, what magazines are on the table? Do they reflect that the clients that you see? If you have a registration questionnaire, does it allow clients to write in their gender or does it make them choose only one of 2 options? So is it reflecting their experience? You can start with an intake questionnaire. Some folks do that very successfully. They start to sort of ask questions about current sexual activity through a questionnaire, and then they follow that up with a private conversation. And the conversation should happen in private and in a comfortable space. It shouldn't happen during an exam. That's not a good way to do it. And confidentiality, of course, should be assured. When you're having a conversation, it's important to let patients know that you ask everybody or clients, that you ask everyone these questions as part of their overall health and well-being. And no assumptions, and I say that with the caveat that, of course, we make assumptions. We all make assumptions. We go through our daily lives making assumptions. What's important is not to let those dictate your decisions or be your final word. So always keep yourself in check about that. I use myself as an example. You can't see me, but if you could, you'd see a white middle-aged woman with a ring on her left hand. And so you might make assumptions about my STD risk based on those things. You might say, oh, she's low risk. Look, she's clearly has a sign that she's in a committed relationship and her demographic is a lower risk one. Well, statistically, you wouldn't be wrong, but you don't know the specifics. Until you have a conversation with me, you don't know what I do on a Saturday night. You don't know what my spouse and I do on a Saturday. You don't know what I do on a Tuesday afternoon. So you need to have these conversations, and you need to find out more information to inform what you're going to recommend for a client. So watch your assumptions about behavior, orientation, identity, experience, history, etc. It's important to use a client's preferred name or pronouns, because if you're not using the appropriate words that they use to identify themselves, you're not really going to earn their trust. So they're not really going to give you important information. Use open-ended questions, and use terms that both you and your patient or client understand. Doesn't mean you have to try to be hip and speak the young lingo, but make sure everybody understands what's being talked about. So here's some really helpful resources, and this is if you're going to like print out a slide or take a slide, this is the one to use. These resources are really helpful, and they give way more information and way more guidance on talking to patients and clients about their sexual health. So there's some really great stuff in these, so I highly recommend that you check them out. So just if you need some extra help, if you want a little extra assistance from the STD program, we are here for you. Our mission is to reduce the burden of STDs on New Jersey overall, on citizens and communities. We do this we can provide technical assistance, we can provide guidance on best practices, we will come and talk to you and provide training. So if you want us, please reach out. If you have providers that want some information about a patient's history, for example, to know if a current test for syphilis is actually a current infection or if it's a past infection, you can call our surveillance unit. The provider can do that and get some information to help with that. So here's just some of our key staff if you want to reach out. And just my phone number and my email. So if you want assistance with training or anything else, please reach out to the STD program. We're here to help you, and we're happy to help. And that's it. Thank you very much.
Thanks, Amanda.
Thank you so much. That was a great topic. Thank you. One more shift again to foodborne disease surveillance update, and our foodborne disease surveillance coordinator, Deepam Thompson.
Thanks, Sharif, and good morning, everyone. So today I'm going to quickly review illnesses that have CDC case report forms, and then take a look at the few 2018 multi-state clusters where CDC had web postings and New Jersey had cases. These are published stats from 2017, but since we're still in the final closeout phase for our 2018 cases, but the Foodborne team here looks through every one of your comments, the data that's collected in approximately 4,000 cases that get reported every year. So this includes everything from a handful of foodborne intoxication cases to about 2,000 cases just for campylobacteriosis. So we truly appreciate your prompt and thorough case investigations. So the timeline in most foodborne case investigations is a positive lab, confirmation at the state lab, and then, if applicable, for the testing by PFG. So PFG is, again, pulsed field gel electrophoresis. That determines if cases match each other. Every case that's reported in CDRSS and meets case definition, whether it's confirmed, probable, or possible, needs to be interviewed to get a thorough food history and relevant exposures. So I'd like to continue to remind everyone to use the checklists from disease pages on the website and the associated case report forms when completing these interviews. Please do not fax the case report forms to the physician's office or case patient's home. Continue to enter the exposures into CDRSS before you fax a form that's required to CDS. And last but not the least, please ensure that illness onsets, travel dates, hospitalizations, and other exposures match those that are in CDRSS, so that our team here doesn't have to pester you over an investigation you've already completed. Since in the past forums I've elaborated on the clinical picture of each of the 5 illnesses that have CDC case report forms associated with them, I will not get into those details, but just let's quickly review what we have on each of these. So cyclosporiasis, as we all know, it's caused by a single-celled coccidian parasite. And most cases that are reported in the US are associated with travel to an area where the illness is endemic or due to the consumption of contaminated imported produce. And as with all nationally notifiable foodborne illnesses, we follow CST position statement definitions. So a confirmed case is one that matches clinical criteria and lab confirmation, while a probable case is one that matches clinical criteria and is epi-linked to a confirmed case. The case report form for this disease includes questions about travel on the first 2 pages of the questionnaire. And if the case patient reports international travel during the 14-day period before illness onset, then the food exposure questions do not need to be addressed. But if there is no international travel, then these questions need to be filled out as quickly and thoroughly as possible. In 2018, multiple outbreaks of cyclosporiasis were identified and found to be linked to different produce items. So last summer, we saw 2,299 lab-confirmed cases reported to CDC from 33 states. And these are people who had become ill from May through August without a history of international travel during the 14-day period before their illness onset. New Jersey had over 260 cases in 2018. And in this chart that you see, approximately 1/3 of the ill people were associated with either of the following 2 large outbreaks in the Midwest. So the first was an outbreak that was linked to prepackaged vegetable trays, and that contained broccoli, cauliflower, and carrots, and it was sold at a convenience store chain. These are the cases in blue. And the second was another large outbreak linked to salads that contained carrots, romaine, spinach, kale, and red leaf lettuce. This was sold at a fast food chain, and these are the cases in yellow. In addition, there were also a few smaller clusters that were associated with different types of fresh produce. New Jersey, however, lucked out and did not have any associated cases with these clusters. Listeriosis. This is caused by the bacterium Listeria monocytogenes. An estimated 1,600 people get sick with listeriosis, and about 260 people die every year. The infection is most likely to sicken pregnant women, newborns, adults, those who are age 65 or higher, and people with weakened immune systems. So New Jersey participates in CDC's Listeria initiative, and this is an enhanced surveillance system. So it collects reports of lab-confirmed listeriosis cases, and the goal is to find and stop outbreaks as quickly as possible. So it becomes very essential for us to collect the detailed information, shopper card numbers, and complete this lengthy questionnaire as accurately and as quickly as possible, because that's what ensures that no exposure is overlooked and that product can be pulled off those shelves as quickly if needed. While probable or possible case definitions are not used for listeriosis, a confirmed case is a clinically compatible case with the isolation of LM from a sterile site. And in New Jersey, approximately 30 to 40 cases get reported every year, with most of them presenting as a very severe illness. Typhoid and paratyphoid. These are illnesses caused by Salmonella serotype typhi and paratyphi respectively. And most people in the United States become infected while traveling abroad. Most often, this is to countries where this disease is very common in the 30 days before illness onset. Again, a confirmed case is one that is clinically compatible with lab confirmation, and a probable is one that is clinically compatible and epi-linked to a confirmed case. New Jersey typically sees approximately 25 cases of typhoid and less than 10 cases of paratyphoid every year. This case report form is fairly simple. It's a one-pager, but with the multi-drug resistant outbreaks in countries, we do routinely have returning travelers from these countries in New Jersey. Please pay special attention to the travel, to the resistance testing, and immunization. Vibriosis. This causes an estimated 80,000 illnesses and 100 deaths in the United States every year, and people become infected by consuming raw or undercooked seafood or exposing a wound to seawater. Most infections occur between May and October when the water temperatures are still warm. And the COVIS form, or the cholera and other Vibrio illness surveillance form, is what's used to report all infections with pathogenic species of the family Vibrionaceae. Another fairly simple form, but an environmental investigation has to follow the EPI investigation. So please make sure that your form captures testing, illness presentation, underlying health conditions, recent seafood consumption, exposure to bodies of water, and sources of implicated seafood. It's information from all these COVIS forms that help determine food and environmental risk factors for these infections. STEC, or sugar toxin producing E. coli. Every year, approximately 265,000 STEC cases get reported nationally, with about 250 cases in New Jersey. And as most of you know, there are about 200 different recognized STEC serotypes, and they are primarily distinguished by the major surface antigens O and H. Non-O157 STEC serogroups typically cause less severe illness, and most outbreaks that we see in the news are associated with our O157s. So if E. coli O15787 is isolated, it's a confirmed STEC case. A case is probable if E. coli O157 is isolated without the confirmation of H antigen or sugar toxin production, or if the case is clinically compatible and epi-linked to a confirmed case. We will also close a case as possible if the person has received a diagnosis of post-diarrheal HUS or hemolytic uremic syndrome, or if a sugar toxin was identified in a specimen from a clinically compatible case without culture confirmation. But none of these case definitions should change case investigation. So CDS-40 needs to be completed on every one of these cases. So in the past presentations, I have explained in detail how multi-state outbreaks are identified and how they're investigated. But to quickly recap, PFG or pulsed field gel electrophoresis patterns get uploaded by every state lab onto the CDC platform called PulseNet, where CDC is able to look at patterns, and not just from New Jersey, but from all around the country, and see if there are cases that match. They're able to see if there are unusual patterns or if there are common patterns that are flagging above baselines. CDC then notifies states of a cluster. And every year, New Jersey has cases in approximately 25 to 30 multi-state foodborne outbreaks, some where a source is identified and some where even the best efforts do not necessarily point to a single vehicle. So over the next 6 slides, I will go over outbreaks where New Jersey has had cases and CDC has had web postings and where implicated sources were identified. So this is the outbreak of E. coli infections linked to romaine lettuce. This outbreak had a total of 62 reported cases from 16 states with 25 hospitalizations, and New Jersey had 13 cases. The illnesses here started on dates ranging from October 7th, 2018 to December 4th, 2018. The Public Health Agency of Canada also identified ill people infected with the same DNA fingerprint of E. coli O15787. And EPI, lab, and traceback information indicated that romaine lettuce that was harvested from the central coastal growing regions of Northern and Central California was the most likely source. This outbreak strain was identified in sediment that was collected within an agricultural water reservoir, which was on a farm in Santa Barbara County. Red leaf lettuce, green leaf lettuce, and cauliflower were recalled, and FDA continues to investigate to learn more about how this E. coli bacteria could have entered the water and how the romaine lettuce could have been contaminated. We'll move on to the next outbreak. This is the outbreak of salmonella infections that were linked to raw chicken products. The CDC web posting for this outbreak was updated on 21st of February, and this slide was prepared before that update. So as of February 21st, this investigation is over. It has a total of 129 reported cases from 32 states, with 25 hospitalizations, and New Jersey had 13 cases. Illnesses ranged from January 8th, 2018 to January 27th of this year. 87% of the people who were interviewed reported preparing or eating chicken products that were purchased raw, including ground chicken, chicken pieces, and whole chicken. So this was Salmonella infantis, that was the outbreak strain, and it was identified in samples from raw chicken products from 76 slaughter or processing establishments, and even from raw chicken pet food. So this sort of added evidence that people in this outbreak got sick from handling or eating raw or undercooked chicken, made CDC and USDA actively engage with representatives from the chicken industry to explore ways to reduce salmonella in chicken products. And because investigation results suggest that the strain is present in both live chickens and in raw chicken products, further investigation and interventions are in place to reduce the prevalence of the strain. This is the outbreak of salmonella infections that were linked to raw turkey products. This outbreak had a total of 279 reported cases from 41 states. There were 107 hospitalizations, and New Jersey had 11 cases in this. There was also a death that was reported from California. This outbreak strain has been identified in samples taken from raw turkey pet food, raw turkey products, and even live turkeys. There were several turkey products that were recalled because they've been contaminated with the strain. However, there was not a single common supplier of raw turkey products or of live turkeys identified with this whole outbreak. So CDC and USDA FSIS have shared this information again with representatives from the turkey industry and have requested that they take steps to reduce contamination. Outbreak of Salmonella Mandaka infections linked to Kellogg's Honey Smack cereals. This outbreak saw 135 people infected with the outbreak strain of Salmonella Mandaka. There were 36 states involved and New Jersey had 5 cases. Illness onsets ranged from March 3rd to August 29th of 2018. And in interviews, 75% of people interviewed reported eating Kellogg's Honey Smack cereal. Lab testing identified the strain in a sample of unopened Honey Smack cereal that was collected from a retail location in California. Lab testing also identified the strain in samples of leftover Honey Smack cereal that was collected from people's homes in Montana, New York, and Utah. On June 14, 2018, the Kellogg Company recalled all of these cereals that were on the market within the cereal's 1-year shelf life. Outbreak of E. coli 015787 infections linked to romaine lettuce. This is the outbreak that New Jersey was the first to pick up on. There were a total of 210 people infected with the outbreak strain reported from 36 states. 96 people were hospitalized, including 27 who developed hemolytic uremic syndrome or HUS. There were 5 deaths that were reported, 2 from Minnesota and 1 each from Arkansas, California, and New York. Epi, lab, and traceback evidence indicated that the romaine lettuce from the Yuma growing region was the likely source of this outbreak. CDC lab testing has identified the outbreak strain of E. coli 015787 in canal water samples taken from the Yuma growing region, and FDA continues to investigate the outbreak to learn more about how the E. coli bacteria could have entered the water. And finally, outbreak of Salmonella infections linked to coconut tree brand frozen shredded coconut. So this was a much smaller outbreak compared to the others. There were 27 people infected with the outbreak strains of Salmonella Newport that were reported from 9 states. There were 6 ill people that were hospitalized and no deaths reported, but New Jersey had 1 case. Epi, lab, and traceback evidence indicated that the coconut tree brand frozen shredded coconut distributed by Evershing International Trading Company was the likely source of this outbreak. Evershing International recalled all of their 16-ounce coconut tree brand frozen shredded coconut after the salmonella was identified in the product. Now, all of these outbreaks would not have been investigated thoroughly, or a cause could not have been identified if food histories and exposures weren't gathered promptly. Moving on to Foodborne program updates. So what's new? We do have a new recall widget that has been posted to the main Foodborne illness page. Over the last year, if New Jersey had cases and every time CDC did a web posting, we have also been posting New Jersey-specific multi-state outbreak updates to the main Foodborne page and the respective disease pages. Talking points, cases that are part of multi-state clusters will continue to be updated through CDRSS, and you will also continue to hear of these cases through your regional EPI. So all questions typically related to these investigations and outbreaks come to us through our communications office. But in the event that you expect questions, we are more than willing to work with you on talking points for those impacted counties, as we've done in a couple of investigations last year. Next steps, NNDSS modernization initiative. The Foodborne team is currently working very closely with CDC and our IT team to implement CDC's message mapping guide for all of the foodborne and diarrheal diseases. And while this implementation is a meticulous and a time-consuming process, the ultimate goal really is to electronically be able to transfer data collected on our foodborne case investigations to CDC. And most of this will include changes to the DSQ or the sources of infection section, but there will be a heads up before this happens, so more to come. Whole genome sequencing, currently in New Jersey, while we can PFG at the state lab, whole genome sequencing for our isolates have only been performed so far at CDC. So we're currently in the process of implementing whole genome sequencing here, and hopefully within the next few months, we should be able to sequence our foodborne isolates. More details on those to follow. CDC measures states for how quickly and completely these case report forms are completed and cluster investigations occur. So over the past couple of years, we have been able to significantly raise our percentages on CDC metrics, but there is definitely room for improvement. So please continue to investigate all our foodborne cases promptly. And as always, feel free to reach out anyone within the foodborne team for questions. Thank you.
Thanks, Deepan. Our next topic will be, I think I like this topic. We will introduce it in next webinars. Quick updates on what's going on, important subjects that you guys need to be up to date on it. We'll start with measles and our measles expert from Vaccine Preventable Disease, Noel Bessette.
Hello, everyone. So today I'm just going to give a quick update on the measles situation. So as you all know, we had an outbreak of measles in 2018 that was declared over at the beginning of this year. So before I get into my quick update on our outbreak, some numbers and information on measles situations going on locally and around the world. So Rockland County, New York, and New York City had concurrent outbreaks with us. So while ours was declared over in January, both Rockland County and New York City still have ongoing outbreaks. So the newest numbers for those outbreaks, as of February 20th, Rockland County is up to 138 confirmed cases. And New York City, as of February 19th, had 90 confirmed cases in Brooklyn. So across the world, there are large measles outbreaks that are occurring, mostly in Europe. The largest is one that's actually occurring in Ukraine. So this outbreak has been going on for almost a year. Last year in Ukraine, they had over 53,000 cases. And so far in 2019, there are already over 20,000 cases. And Israel, which is where all three of the New York and New Jersey outbreaks started from, has had over 3,400 cases through the end of January. So all three, Rockland County, New York City, and New Jersey, had outbreaks that occurred when someone traveled from Israel to the U.S. Other parts of Europe are also experiencing outbreaks with very large numbers and a lot of deaths. So in terms of the New Jersey outbreak that occurred at the end of 2018, our index case for this outbreak was someone that as I had mentioned, had recently traveled from Israel to New Jersey. The rash onset date was October 17th, and this person reported a fever, cough, coryza, and a rash. Unfortunately, this case was not reported upon suspicion, so we received word of this individual when a lab report was entered into our system. So unfortunately, it was a delayed report. For measles, an outbreak is considered 3 cases in a setting. So we declared the outbreak on November 1st when our case count reached 3. And our total case count, so our outbreak was declared over on January 16th of this year. The total case count associated with this outbreak was 33 confirmed cases. 30 of those cases occurred in Ocean County residents, and then we had one single household in Passaic County that had a direct link to Ocean County. So while these individuals lived in Passaic County, they had a link to Ocean County and were counted as part of our Ocean County outbreak. The age range of our cases ranged from 6 months to 59 years. The majority of the New Jersey cases were unvaccinated. The onset dates ranged from October 17th through November 30th. And again, the outbreak was considered over as of January 16th. And on this next slide, you can see an epi curve of our cases based on their onset date. And then at the end, you can see the 42 days, the 2 incubation periods from the last day the last case was infectious. So as is the case with many outbreaks, we wait 2 incubation periods to declare that outbreak over. Since there are ongoing outbreaks in New York, we are still recommending that providers remain vigilant for cases of measles. So, I think all of you are getting a lot of reports of rash illnesses, but we know that the populations go back and forth. People travel to New York and back all the time. So, we want providers to still think measles, even though we don't necessarily have an ongoing outbreak in New Jersey right now. And that is all I have. Thank you.
Next quick update on AFM, or acute flaccid myelitis, with Susan Hannigan, our epidemiologist with vaccine preventable disease.
Good morning, everyone. So I'm going to be giving just a quick update on what was going on with acute flaccid myelitis in 2018. For those of you that are not super familiar, acute flaccid myelitis, or AFM, is an illness that's characterized by a sudden onset of limb weakness. It's an illness that affects the nervous system, specifically the gray matter area of the spinal cord, causing the muscles and the reflexes in the body to become weak. But despite extensive testing and surveillance over the last couple of years, CDC does not know the specific pathogen that's causing most of these cases of AFM. So we've been doing surveillance for AFM here in New Jersey since the second half of 2016. CDC initiated their surveillance for AFM starting in 2014 after receiving reports of these cases in August of that year. You can see in this graph, this data is from CDC, the cases have been peaking every other year in the late summer and early fall months, so August, September, and October. And that trend that we're seeing nationally has held true in New Jersey as well. Both the United States as a whole and New Jersey reported the largest number of cases in 2018. So there were 215 cases in the U.S. From 40 different states, and there were 10 cases here in New Jersey that met the confirmed case definition. These numbers are as of February 15th. So CDC is still classifying a few cases that were onsets and reported in 2018. So we do still have one case in New Jersey who was reported in 2018, but is still under investigation for its case classification by CDC. So these numbers may still change, but we have not had any reports of AFM in New Jersey for 2019 so far. So just a quick summary of some of the information, what CDC has seen so far after these couple years of surveillance. Over 90% of the cases are in children, and all of the cases confirmed here in New Jersey were less than 18 years old for 2018. CDC believes that viruses likely play a role in AFM. So more than 90% of patients with AFM have reported a mild respiratory illness or a fever consistent with a viral infection before developing the limb weakness associated with AFM. The peaks in the cases are being seen around the same time of year that many viruses commonly circulate in the late summer, early fall, including enteroviruses, but CDC is still investigating why the peaks are only occurring every other year and what association this might have with the cases of AFM. Respiratory illnesses and fever caused by viral infections obviously are very common, especially in children, and most people do recover. So we still don't know why a small number of patients then go on to develop limb weakness and symptoms of AFM. At this time, there is still no action that's requested of local health departments for AFM cases reported in New Jersey. Cases are entered in CDRSS when they're reported to us here at the state, so they can be viewed by local health departments if there's a case in their jurisdiction. But we don't know what is causing most of these cases, so there's no specific action to take in order to prevent AFM. The current recommendations from CDC are just to continue to practice proper hygiene techniques that can decrease risks of getting general viral infections. We sent a links message out in October just as a reminder to providers in New Jersey to report suspect cases of AFM to the State Health Department. The process of reporting is for the doctors to fill out a patient summary form and send us copies of the medical records, which we send to CDC in addition to MRI images for them to review and determine if the case meets case classification, as well as testing specimens. We have been updating our numbers on the website as of this fall when there was increased media attention surrounding AFM, and we'll continue to update the website with changes in numbers going into this year. And the only thing that's upcoming for the future, CDC is interested in better understanding some of the long-term outcomes of individuals with AFM. So they are requesting that states start conducting follow-up with confirmed cases, but they're in the process of finalizing the follow-up questionnaire and what that will look like. CDC has been continually updating their website and have been adding new information, so that's a good resource to check out, as well as our own website, and feel free to reach out if you have any additional questions.
Thanks, Susan. Another switch to ZD. We didn't have any zoonotic disease today, so our Kristen Graflo, the expert on vector-borne disease, update from Kristen.
I'd like to start today by welcoming a new member to the New Jersey Department of Health Vector-borne Disease team. Her name is Michelle Malinowski. As many of you may be aware, Lindsay Lau has received a promotion and is no longer working on Lyme disease. Michelle is a second-year graduate student at the Rutgers School of Public Health who will be with us on a temporary part-time basis to perform Lyme disease case review and closeout. So you may be receiving emails or messages from Michelle regarding your Lyme disease investigations. If you have any questions regarding Lyme disease, you can feel free to reach out to her. Her email is here listed on the screen. So it was a really busy year for mosquito-borne diseases here in New Jersey. There were increases in reports of chikungunya, malaria, and West Nile virus. This data on the screen is as of February 20th. So in 2018, there were 199 reports of West Nile virus, which is 67% higher than in 2017. Of these 199 reports, 61 met case definition. This is the highest number of West Nile cases we've had to date here in New Jersey. While the exact reason of why we saw a record-breaking year of West Nile is unknown, the weather most certainly contributed to it, with a mix of hot and wet periods led to more mosquitoes and led to amplification of the virus. And it's also interesting to note that surrounding states saw an increase in cases as well. And there's research currently underway to study the virus itself to determine if a new variant could have possibly emerged. Interestingly, there was a decrease in most tick-borne diseases except for tularemia, which remained the same, and Borrelia miyamotoi. So just a reminder that there's still a large number of tick-borne disease cases that still need to be investigated and closed out by the end of March. While worksheets are available for many of these diseases, a phone call to the healthcare provider or the patient may be needed if you're not receiving a response from the healthcare provider. The presence of a fever is an important symptom for almost all of the tick-borne diseases. If the patient didn't have a fever on the day that they saw the healthcare provider may report this as no fever. In these cases, it's important to interview the patient and ask about fever during the course of illness. The exception to this is Lyme disease, since all the clinical information must come from the healthcare provider or a staff member at the practice, such as a nurse or an office staff member with access to the patient's chart. So in those cases, there's no need to contact the patient. Also, we recommend that a minimum of 3 attempts be made to obtain the required case details. After 3 attempts, enter what's known into the case, into CDRSS, including the dates and results of all the attempts that you made to obtain the information, and then you can just classify and close out the case according to the case definition. In 2018, we saw an increase in reports of Borrelia miyamotoi. This is an illness that is not nationally notifiable. However, we have requested voluntary reporting in New Jersey. Since it's not nationally notifiable, there's no standard case definition. However, there is a working case definition in an attempt to facilitate coordinated data collection across states to better define the spectrum of illness associated with the infection. The working clinical case definition includes any acute onset of fever or chills with one or more of the following symptoms. So a headache, sweats, chills, myalgia, arthralgia, malaise, fatigue, rash, abdominal cramps, nausea, vomiting, diarrhea, dizziness, confusion or altered mental status, photophobia, leukopenia, thrombocytopenia, and elevated liver enzymes. So the case definition is very vague because we really want to learn as much as we can about this infection since there isn't a standard case definition at this time. New Jersey had 26 reports of Borrelia miyamotoi in 2018, with 2 confirmed and 4 possible cases. 13 reports were investigated, but it didn't meet the case definition, and then 7 cases are still under investigation or review. 2018 was the first year Borrelia miyamotoi had been reported in New Jersey. These cases were found in both the northern and southern portions of the state. So if you receive a report of Borrelia miyamotoi in your jurisdiction, please reach out to your regional epidemiologist for a copy of the case report form that I have here on the right-hand side of the screen. Once you complete the form, enter the information into CDRSS, and then send a copy of the form and any laboratory results, including co-infections, to the New Jersey Department of Health using the CDS Vector team email listed here on the screen. If you're using secure email, if not, please fax the form to the phone number listed on the screen.
Finally, our last slides, we usually keep our best for last. Our Alison Portney from Vaccine Preventable Disease with update and Hepatitis B.
Well, I'm flattered to be a part of your finale today. The Hepatitis B surveillance team wanted to bring your attention to a new material that we posted on our website. You can see it on the left side of your screen. It's our new Hepatitis B case classification algorithm. We hope that it will help you with your 2018 case closeout and onwards into the future. It can be found on the website on the Hepatitis B page. And you may have already received a copy of it via email. If you have any questions about the algorithm or come into contact with a case that doesn't seem to meet any of those criteria, we would be happy to speak to you. Please feel free to call or email us at any time. And that's my update.
Thanks, Alison. Now we get to your questions. If you have any questions, you can type it actually at the question box right now. First question
is, what is the procedure for getting foods tested at FEL during an outbreak, and what test for foodborne disease does FEL conduct?
So I'll approach the first question it's a two-part question. What is the procedure for getting foods tested at FEL during an outbreak? The outbreak word over here is two-pronged. So there are in-state outbreaks and multi-state clusters or multi-state outbreaks. For the in-state outbreaks, so these are the event-specific ones, post your weddings, post your parties. There is a lot of data that needs to be collected and a clinical testing that needs to happen before you can really determine what the pathogen is. So unfortunately, at FEL, we do not have the resources to run all the enterics to determine what that pathogen is. So I'm sorry, there is no capacity currently to test foods for in-state outbreaks. Now, the multi-state cluster outbreaks, these are ones that you already know what the pathogen is. There has been clinical testing at FEL. PFG matches have been done. Sometimes there's whole genome sequencing that CDC has performed. So we typically know what the pathogen is, and you've sort of identified the implicated product, either at a person's home or an unopened package. In those scenarios, if enough testing hasn't been done by other states, then yes, we will try to push for that testing and get that done at FEL. So that's no to the in-state, and yes, if a multi-state cluster case warrants testing. The other question is, what tests for foodborne diseases does FEL conduct? I know Lisa in her slides referred to 857. So anything by regs that needs isolates submitted to FEL, FEL will test for. So that includes everything from your Salmonella, Shigella, your Stex, Listeria, typhoid, Vibriosis. Cyclo that I mentioned during my slides does not go to FEL. Campylobacteriosis that we see the most cases for do not go to FEL. But if anybody would like a copy of these, or you want to see a link of where this exists, feel free to call me or reach me via email, and I'm more than happy to share that information.
Thanks, Deepa. The next question we have is for Susan about the AFM presentation. The question is, do the children have a resolution of the weakness and numbness?
So this is a great question, and this is why we're hoping to implement this long-term follow-up in the future so that we can get a better sense of what the prognosis of these cases looks like. In general, CDC has seen, kind of all kinds of outcomes. So for some individuals, this illness does result in long-term paralysis of the limbs that became weak. Some individuals have improvement but need a lot of physical therapy, but some cases have also shown full recovery. So we don't have good data on this, but we're hoping to do so in the future with more long-term follow-up of these cases.
Thank you. We have another question for Deepam that just came in. Please define a food handler when talking about work restriction for foodborne illness.
We approach food handlers on a case-by-case scenario, but in a simple one line, it's anybody who really prepares or touches food with their bare hands. But in cases of exclusion where it's not as clearly defined, we're more than welcome to take those calls and entertain those discussions.
Great. Thanks. And this one is for Barb Carruthers with the school outbreaks. And the question is, do universities have the same reporting requirements of K through 12 schools?
Yes.
That they have?
Yes, they do. So the regulations pertain to youth camps, child care centers, preschools, schools, and institutes of higher education. So they're bound to the same reporting requirements. And just to tag on Deepam's question, a food handler in a daycare center is the nice lady who hands out snacks. So consider those folks when you have foodborne outbreaks as well.
Thanks. And then we have a question for Lisa about flu. When we have an inpatient tested for flu, how long should we keep the patient on droplet precautions?
So in general, I would refer folks who are asking this question to the HICPAC requirements that CDC publishes. I apologize, I don't have the link in front of me, but you have my contact information. If you'd like a link to that document, we can certainly send that to you. In general, if a person is confirmed with an influenza, they should remain on droplet precautions until they're no longer symptomatic. And we can provide that document to you. If you want to shoot me or my team an email, we can get that out to you. There's another question on here about
an antiviral.
Antivirals. Again, the department does not provide clinical recommendations regarding the treatment of influenza. I refer to you any questions about the available antivirals to the link in the document in my slides that the CDC has published, which talks about the different antivirals that are available for treatment and their course and their diagnostics. They provide a very nice overview of all of those, and so I would refer you to that document of the summary of all antivirals available for the treatment of influenza.
There's another one about local health departments being made aware of pediatric influenza deaths before hearing it on the news or from the public.
So, unfortunately, influenza pediatric deaths are a non-immediately reportable condition. Occasionally, we hear about them from the news or from the public. And so, again, our team here does try to look closely at all influenza case reports from children less than 18 years of age, and we try our best to determine if there's a potential for those children to result in an ICU admission or a death. Unfortunately, some of these children are tested in their pediatricians' offices, which do not report those influenza reports to the state health department through CDRSS, and so there are often times when those are missed. So again, if you hear about a pediatric influenza death before making comments, I'd appreciate it if you just call up and talk to our team so we can work with you on trying to best understand if in fact that person meets the case definition or what additional information that we have in order to determine if there is a possible case of pediatric flu.
So Lisa, is flu ever going to be made mandatory for New Jersey healthcare workers? Is there any push towards that? Flu vaccine, I'm sorry.
Again, I don't work for the Vaccine Preventable Disease Program, who would be the folks who would oversee that. I know that we encourage influenza vaccination in healthcare workers throughout the state of New Jersey. I can't really speak to whether it will ever be made mandatory. Again, we're not part of the legislative body. We do make recommendations and strongly encourage vaccination of healthcare workers. At the current time, it is not. It is based on policy within the healthcare organization themselves.
And then which cases are not required to be investigated for influenza A?
So again, influenza, while it is a laboratory reportable condition to CDRSS, only those cases who are in children less than 18 years of age who've been admitted to an intensive care unit or have died, or a case that is associated with a novel influenza presentation are the only ones that need to be investigated. All others can simply be ignored in CDRSS, and the flu team here at the state will close them out.
Thanks, Lisa.
Welcome.
Deepa, I have a follow-up question for you regarding FEL as a resource for local health departments during a foodborne outbreak.
I'm guessing this refers to the local foodborne outbreaks that I talked about before, the event-specific ones, and I'm sorry, FEL does not have the resources currently to test for food.
Okay, great. And then I have an STD question, Amelia. Are there any plans in the works for opening up more STD clinics for testing to lessen the amount of patients going to the emergency rooms for treatment?
This is a really great question. We are very aware of the lack of STD clinics in the state. The state of New Jersey Department of Health does not provide clinical services. That is sort of under local health departments, which does not mean they need to directly provide it, but they do need to assure STD clinical services in the jurisdictions that they oversee. So that can also happen through FQHCs, family planning clinics, and what have you. But any questions about that would be best directed to your local health department to see what ways they have to ensure STD testing services, clinical services.
Amelia. Mm-hmm. And then our next question for Allison. What was the reason for the new case classification for Hepatitis B, the new algorithm?
We created the algorithm because there are a lot of confusing tests for hepatitis B, and there are a lot of different ways to meet case definition. So we created the algorithm in the hopes that we can make it a little bit easier for everybody to classify those cases when they have confusing lab results. But we also wanted to make sure that there's not confusion between probable and confirmed cases, because those we've also seen flip back and forth. And we want to make sure that local health departments have as many resources available to them when classifying cases.
Thanks, Allison. And Amelia, we have another question for you. For STDs, are there recommendations for testing of adolescents as best practice for this age group?
Yes, CDC does have STD testing and treatment recommendations. And if you use the Google, you can even just Google CDC STD screening guidelines, and you should probably find a link, or you can go to the CDC website and find it there.
Thank you.
Okay, that gets us to the end. Thank you for your time and attendance today. Please watch in your email for the link to the survey for evaluation that has to be completed within 5 days so you can get your certificates. We will wish to see you guys in our in-person training in April, May this year. Thank you so much. I'll talk to you soon.
Thank you.